Or are you going to introduce?
I just did.
Oh,
So welcome,
that.
Dr. Jade Teta. You're ready to go.
Okay, I'm ready to go. As you can tell, everyone, I don't speak Spanish, so I was like, I guess I'm ready to go. All right, so let me just share my screen with everybody, and I'll leave my video camera up so you can see me, and I'm also gonna share my screen. So let's, and maybe you could just let me know that you see that okay? You can hear me and see me all right?
Yes.
Okay, perfect. Okay, so welcome everybody. I know this topic is one that is very much on our minds and on the minds of our patients and clients. And so I'm going to do my best to give you the full treatment of the GLP-1 medications and help you understand the physiology, the psychology, the dosing, the effects, the side effects, everything there is to know about GLPs. And you'll have to forgive me. I only speak English. I do not speak Spanish. I wish I was bilingual. I'm always amazed that people are. But when we get to questions at the end, what I'll do is we'll wait for questions to the end, I assume, and then I will take questions. So I'll try to get through this, probably take, I don't know, 60 minutes or so, maybe slightly longer. Any of you who want the slides, you can get them by going to this link here, gohuman.io/GLP. It will ask you to put your name and email in. It will put you on my email list, but you're free to unsubscribe. But that will give you the downloadable link. All right, so let's get started. And hopefully, if you want those slides along the way, you can just remember that's the link to go to. So let's go through overview and objectives first. What we're going to cover here, history and evolution of GLP-1 therapies, and I'll help you understand what we mean by GLPs, the physiology of GLPs, and the drug class and the different drug names. You're going to learn the physiology, and we're really going to get into, I think, something that most of you are probably interested in, the evidence based around nutrition and lifestyle strategies for people who are using these and also people who are coming off of these medications. We're going to really get into both GLP-1 and GIP. Some of you may understand that there are drugs like tirzepatide and others that are using both of these compounds, and they have better effects in some ways. And we're going to learn to understand all these different medications, as well as the clinical risks, dosing concepts, including microdosing, and that there is some evidence that these medications may be used in psychiatric medicine and addiction medicine as well. So by the time you get through this talk, you should understand these medications. You should understand the nutrition, supplement, exercise strategies that you can use to support them and everything else. And so before we do that, let me just briefly introduce myself, Dr. Jade Teta. I know that last name is funny for all of you who speak Spanish. We pronounce it Tita, but I have been made aware that it is Teta in Spanish. I am of Italian descent, so you'll have to forgive me. You can get a little chuckle out of that. Whenever I'm in Puerto Rico, everyone kind of takes a second look when they hear my name. Uh, I am an expert in metabolism. I've actually been doing this work for 35 years. And I say 35 years, I'm 52 years old. I began this work at 15 years old. That's the first time I got paid as a personal trainer to do this work. And I've been doing it ever since. I have a bachelor's degree in biochemistry. I have a doctorate degree in natural medicine, specifically functional medicine. I graduated from Bastyr University in 2004. I'm currently working on my PhD in transpersonal psychology, and my specialty, believe it or not, is endocrinology. I've spent most of my career working with female hormones, HRT, and male hormones, testosterone replacement therapy, hormone replacement therapy. So I have worked a ton with mainly women, and I give and these talks a lot for Institute for Functional Medicine, the American College of Anti-Aging Medicine, the Personalized Lifestyle Medicine Institute, and others. And so I'm incredibly happy to be here. And I have been doing this work for a very long time without these medications. And of course, many of you have as well. And I can tell you I have gotten pretty good results, but if I'm honest, weight loss is probably the hardest thing I've ever done. When people ask me, hey, Jade, what do you do for a living? And I tell them I spend most of my time in weight loss. And then they ask me what that is like. I typically tell them, hey, look, if you want to fail most of the time, then you have an idea of what my life is like. I have had very good success, but not great success because our track record in this world in general is pretty bad. To give you an idea of the weight loss world without these medications, about 80% of people do not lose the weight and or keep it off within a year. At 2 years, it goes to about 90%. At 3 years, it's 97%. At 5 years, 99% of people who tried to lose the weight and keep it off end up gaining it all back. Now, I have seen people lose huge amounts of weight. I've mainly worked with women, and I can tell you that I am excited about this class of medications because anything that we can do that helps this work, from my perspective, is a good thing. And that does not mean they don't have some downsides, and that does not mean there aren't things that we all need to be aware of. So that is what we're going to cover. I just want to show you that I've been around. These are all books that I have written. For those of you who don't know me, who want to get into this work or get into my work, this book is probably the one that will most cover what we cover today, this book, Next Level Metabolism. But let's get into what you actually came for. And let's first start with the history of these medications. And actually, the history starts with this organ right here, the stomach. And believe it or not, right before I went to medical school, this would have been back in 1996-ish, I was in a lab out of East Carolina University where they were doing stomach bypass surgery. And what's really interesting is the lab that I was in, Dr. Hasham Barakat, he was doing this work, and he was basically showing that something happened when you took people and did stomach bypass surgery. The whole idea then was, if we do stomach bypass and we create a little pouch in the stomach, we decrease the amount of food people can eat, and they will lose weight because we restrict the amount of volume or food that people can eat. But what they found was really interesting. They found that after they did these surgeries, people's diabetes cleared up within days. People started to have pretty profound effects metabolically before they started to lose weight. And this is the beginning of the story of these GLP-1 medications. And the story starts with what we call incretins. Now, these molecules basically come from the small intestine. And so when food passes into the stomach and begins to drop into the upper small intestine, the duodenum, there's these little cells that line this area of the intestine. And you can almost think of these as like little finger-like projections that are continuing to taste the food. So you're not getting the hit of sweet or savory or sour in your small intestine, but these cells are still tasting the food. They want to know what type of food is there. Is there fat there? Is there carbohydrate there? Is there protein there? And then what they're doing, these cells, is they're secreting compounds called incretins into the bloodstream, and then those compounds go around to the brain and say, hey, brain, this is the kind of food that's coming in. They go to the pancreas and they say, hey, pancreas, we've got glucose coming. You need to release some insulin. They go to the stomach and basically say, hey, stomach, slow down, decrease gastric emptying. And they communicate all over the body, including in the thyroid gland and other areas. And so these incretins, these signaling molecules, these hormone-like peptides, are what we're talking about when we're mentioning a drug class like GLP. This, by the way, was that original surgery. So what they would do is they would go ahead and cut into the stomach like this and create a little pouch. And then they would take this part of the duodenum and connect it. So you had this. And what that did was left out this area. Now, what's interesting about this area of the small intestine is that there's certain kind of cells that line this. Primarily what we call K cells, which release one type of incretin, which we'll get to in a minute, and secrete less of another type. Now, GIP, gastric inhibitory polypeptide, this particular compound lives here. And GLP, glucagon-like peptide, tends to be secreted here. And so when you do this particular surgery, what ends up happening is you alter the ratio of these incretins. And so this was the beginning of the story of these compounds. All of a sudden, we thought we were dealing with calories, but when we did this surgery, we actually changed the ratio of two different hormone-like peptides that had metabolic consequences. By the way, this surgery was named after Cesar Roux. This was the first person to do this intestinal connection. It literally translates into Roux's Y connection. This was meant to reduce the amount that people could eat, but what it created was these unintended consequences that resolved diabetes prior to weight being lost. And here's what this looks like. In the small intestines, you've got K cells and you've got these L cells. And these cells essentially taste the contents of the small intestine. The K cells secrete GIP, gastric inhibitory polypeptide, and the L cells secrete GLP, glucagon-like peptide. And they secrete these, and then these things go out and communicate with the brain, the pancreas, and the stomach. Now, the degree to which these are secreted depend on the types of food that we eat. And so when we eat stuff like carbohydrate and fat together, we get more GIP. When we eat more things like protein, fiber, fat with less carbohydrates, we get more GLP. So I want you to see that you're making these compounds all of the time in the body. Now, this is the Gila monster or Gila monster. And this particular animal secretes a GLP-1-like product in its saliva. And this was the first time, once we understood what was happening from this gastric bypass surgery, we started to look that this compound, GLP-1, that looked very similar to human GLP, was present in the Gila monster. And basically, we started to make this particular compound, and this was the very first GLP-1 drug, exenatide. Now, one of the things that I want you to understand is that the modern drugs are a little bit different, and they're a little bit different than the GLP that we make. And so these aren't completely bioidentical peptides. Human GLP-1 has a half-life of about 2 to 4 minutes, but the Gila monster, saliva, GLP, has a longer half-life. And the modern day drugs are altered to some degree to give a longer half-life. So it acts more prevalent in the body. It lasts longer in the body. Now, this is important because what you will hear oftentimes is, oh, well, just eat more protein and more fiber and you'll get more GLP. Or just eat certain types of probiotics and you'll get more GLP. And that might be true, but that GLP that you're getting naturally does not last as long as the drugs do in the body, which is why the medications, even though they look very similar to our GLP, are not the same as the GLP that we release naturally. They last much longer and therefore have much more profound effects. Now, this is a confusing slide, but I want you to see all the different effects they have. Here's what GIP does. It stimulates bone formation. It also stimulates fat accumulation. It makes you gain fat. It can enhance memory. It increases insulin and glucagon. It has these impacts on the pancreas, and it decreases gastric acid secretion. Now look at GLP. It has some of the same effects. It has similar effects on memory, but one of the things it has that's different than GIP is it decreases food intake. It has some satiety effects. Both of them increase insulin, and also GLP slows gastric emptying. That's one of the reasons why it decreases food intake. So there is some overlap in their mechanisms, but GLP is the major one that has the satiety reducing effects. So you can kind of think of these two compounds as yin and yang. They have some overlapping effects. GIP and GLP do some similar things in the body, but GLP is the one that has the major impact on reducing hunger. Now, one of the things that you'll see as we start talking about these medications is that GLP alone does not seem to act as powerfully for weight loss as when you combine it with GIP. And we'll get to that in a minute. But GLP is going to be the dominant sort of medication here. So to make it simple for you, when you eat fat and carbs, you're going to get more GIP. That's going to increase insulin, increase glucagon, increase fat gain, and have some bone benefits. When you eat more fat, fiber, protein, bitter foods like coffee and cocoa and hops, sours like vinegars and citrus and yogurts, and some probiotics, you'll get more GLP, and you'll see the differences. Both of them increase insulin, but then they have opposite effects in these areas. And what we're mostly interested in for our impact here is this decreased appetite. Now, by the way, this also has some ramifications for inflammation and other things. One of the things I want to tell you is that obviously when you look at these insulin effects and these glucagon effects, you'll see that GLP seems to be more prevalent and beneficial for diabetes. And so that's the reason why these compounds are used both for weight loss and diabetes. Now, one of the things you need to understand to completely understand this class of medications is that in the body, when we eat food and we release GLP, of course, GLP is going to go to the stomach, it's going to go to the liver, it's going to go to the brain, but it also is degraded pretty quickly. It is cleaved by this particular enzyme here that basically blocks GLP and quickly takes it out of the body so it doesn't have powerful effects. This is why our natural GLP is not as strong and cannot take the place of these medications. So these DPP-4 inhibitors, dipeptidyl transferase 4 is this enzyme. What it does is it cleaves and blocks GLP-1, and you do not get these effects. Now, why am I bringing this up for all of you? Because you will also see certain drug classes, which we'll cover here in a minute, that you may get confused as GLP-1 agonist drugs when they're not. Basically, what they are is they're just blocking this enzyme. So there's several different ways we can medicate here with GLPs. We can give GLP, or we can give something that blocks the enzyme that degrades GLP. And you will see these drugs, and we'll cover these drugs. But I just want to be complete for you so you understand exactly what we're talking about here. And here's that mechanism again. You eat food, you release GLP. GLP is then cleared from the system by this enzyme. There are drugs that can decrease this enzyme activity and therefore give us more GLP-1. That is different than medications like semaglutide or Ozempic that actually are a GLP-1 analog. So you just want to know the difference in terms of what your patients and clients are taking. So, because some might be taking a DPP-4 inhibitor and not a GLP-1 medication. But they're acting in similar ways. So before we move forward, let's just go and get some vocabulary and some nomenclature out of the way so we're not confused with these medications. The first thing you need to understand is the different names. So the drug class is GLP-1 receptor agonist or agonist. Sometimes you'll see it as a GLP-1 RA, which just stands for receptor agonist. What this basically means is these compounds stimulate and look very, very similar to GLP-1, and they bind to the same receptors in our body and have the same effects. An example of a drug name, a generic drug name for a GLP-1 receptor agonist would be semaglutide. And then the brand name would be Ozempic. And so I just want you to understand when I say a GLP-1, I'm talking about all compounds, all brand names, and all drug names. But if we basically say semaglutide and Ozempic, Wegovy also is a GLP-1 agonist and semaglutide, but it has a different name. And so I just want you to be clear on that. Now, also, some of your patients and clients are going to be taking dual agonists. These would be both GIP and GLP-1 agonists. So it has GIP and GLP action. So an example of that would be tirzepatide as the drug name, and then Mounjaro or Zepbound as the brand name. And so you just want to be clear that the brand name, there are many, many different brand names. These are the most popular. Mounjaro, tirzepatide, is a dual agonist. Ozempic, semaglutide, is a GLP-1 agonist. Many people will be taking the generic version of these, and they'll go by these names, or they'll be taking a brand name. Now, you haven't necessarily seen this yet, but coming quickly on the horizon are triple agonists. Oxyntomodulin, will cover that, is another incretin compound that is now being given along with GIP and GLP. And so now we're getting triple agonist drugs. An example would be retatrutide. And there is not yet a brand name for this particular class of drugs. But I just want you to see that as these drugs and medications gain in popularity, you will start seeing more and more names come up. And you're going to want to understand, okay, well, that's a GLP-1 agonist, that's a GIP and a GLP-1 agonist, that's a triple agonist using other incretins like PYY or oxyntomodulin or other potential compounds. And so you're just going to want to understand that so you don't get confused on all of the different medications. And then, of course, you have these DDP4 inhibitors like sitagliptin and Januvia. So I just want you to understand these are all the different drugs that you may encounter with your clients and patients that they might be taking. Now, this is just a chart that I wanted you to have. I know charts like this are confusing to look at. I just want to, this is just for you to be able to have so you can see the drug classes, right, and see the generic names and see the different brand names, right, and also see that these were the original GLP-1s. They were more short acting. So here's exenatide, the original one, and the brand names, Byetta. GLP-1 receptor agonists that are more long-lasting. These are the ones you're used to, semaglutide, right? And the brand names, Wegovy, Trulicity, Victoza, Ozempic. And then you have the dual agonists here, the GLP-1 GIP agonists like tirzepatide or Mounjaro. And then you have the new ones that are coming out that basically work on all three of these. So I just wanted you to see that. Right now, this is the class you're going to see the most. Most of your clients are going to be on these particular medications. Very quickly, you're starting to see them move to the dual agonist and Mounjaro, this one. So those are going to be the most popular. And these here are on the horizon. You're going to be seeing these very quickly. And one thing I'll say here is that typically what you're seeing is the weight loss effects are a little bit greater with the longer lasting, the dual agonists, and the triple agonists. So this particular class is showing the best weight loss and is currently in clinical development. So here's another chart that basically can show you what the average weight loss looks like. And as you can see, these compounds are the Wegovy, semaglutide, Ozempic, semaglutide, Rybelsus. All these are the same. And I want to show you that in research, some of them get slightly better results. And that's because even though these compounds are essentially semaglutide, they are a little bit different in terms of the way they look. They're not exactly bioidentical. And so that's one of the things you'll find. And you'll also find that it varies in the research. With these compounds, dosing definitely matters for weight loss. And this is something to be aware of because many people are microdosing or doing lower dosing, and they're not getting the weight loss effects because the doses aren't high enough. And so I want you to see these doses. Here are the drugs. Here are the typical starting doses that a doctor will give you, but here are the therapeutic doses. So for example, with semaglutide, most people will start at 0.25 milligrams, but you don't really start seeing much of the weight loss effects until you get to about 2 milligrams to 2.4 milligrams. And this is a big misunderstanding with a lot of people. It's important because we start low with individuals because there are side effects with these drugs that we'll talk about. And many people, not many people actually, most people do just fine, but there's a small percent that don't do well. And so typically what we will do is we will give a little bit of a lower dose and slowly ramp people up. And it's not until they start ramping up to 1 milligram or 2 milligram that they start seeing the doses. Now, some people microdose. So these would be doses less than 0.25. And there is some benefit here in some people. Some people do show decreased appetite and some positive effects with this. But I just want you to see, at least in the research, we're typically not seeing results until we're getting up into those higher doses. Basically, weight loss also doesn't start to occur right away. So you want to let your clients know that the weight loss effects begin to occur after about a month or two and begin peaking at about 16 weeks or so. And so it's just useful to be aware of this because what will happen is a lot of people will expect, and a lot of patients will expect, I get this medication, I start losing weight immediately. Really, what's going to happen is they're going to get this medication at a lower dose potentially, slowly need to bump themselves up to the higher dose, and then once they hit that higher dose, they're going to need about 4 to 8 weeks to begin seeing some of the weight loss results that are typical. And there may be side effects along the way. So you as a practitioner or a nutritionist who's working with someone, you might be the first person ever to tell them this, because let's all just be honest. Most of us doctors who are in primary care and prescribing these drugs don't do a great job communicating this. We oftentimes give pamphlets and other things that our clients and patients don't actually read. So you may be one of the first ones who are talking to a client about this and explaining to them why they're not seeing the weight loss, and also being one of the first ones that are encouraging them perhaps to increase their dose or to ask their doctor to increase their dose because they're not seeing results at 0.5 milligrams. Now, what kind of results can people get? Now, again, I know these charts can be confusing. I apologize about that, but they're there just for you to refer back to in your clinical practice. But this is where you will start seeing average weight loss. So semaglutide, 30 to 50 pounds over about 9 to 15 months, 15 to 22 kilograms, right? So that's about 12 to 18%. The problem is about 66% of people will regain their weight after a year of stopping, right? So that there is a regain here. And that weight typically begins to come back on 2 to 5 months post continuation. This is where nutritionists and coaches really have a role to play, and we're going to talk about how you can keep that from happening and how people can come off. But at least you can see, obviously, there's some pretty substantial weight loss that can happen here. Look at tirzepatide. It's slightly better, right? It's slightly better. But the regain weight is exactly the same, right? And so what happens is with tirzepatide, you get slightly better weight loss, but all of these people tend to regain at about 40 to 60% within the year. This one right now is the one that is producing the best results. And here is the weight regain. It's relatively the same in all of them. So let's now cover what are the common side effects. Well, the most common one is nausea. And some of that nausea can be so severe for people that they will stop taking these medications. Some people will not just get nauseous, they'll vomit. There's diarrhea, there's constipation, essentially a bunch of gastrointestinal upset, which makes sense given these are impacting the digestive tract and are compounds that are released from the digestive tract. And of course, for some, this is a side effect. It's actually the main side effect we're trying to basically use to our advantage. Besides some of the impact it has on insulin production, for weight loss, we want appetite suppression. For some people, though, appetite suppression is excessive and they don't want to eat at all. Headache, also fatigue. Some people have some pretty, great fatigue, and all of these can keep people from wanting to continue. Dizziness is another one. And then, of course, there is a slight risk of injection irritation. And just in case there's some of you who don't know how these drugs are given, they're given essentially with an insulin needle, a tiny little needle, usually in the fat pad adjacent to the belly button. And so it is a sub-Q injection. Now, there are some more serious side effects that we need to talk about. Pancreatitis. Now, pancreatitis is obviously a big one because that's going to be an emergency room visit if someone gets pancreatitis. We'll talk about part of the reason pancreatitis is happening, I believe, is because the individuals are being presented with a medication that is essentially slowing gastric emptying and slowing down the digestive tract. And many of these people are not told by their physicians that they don't want to be eating big fatty meals and things like that. That can trigger pancreatitis. And so we'll talk about the idea of definitely you still have to pay attention to your nutrition, and you probably want to move to smaller meals. Gallbladder disease is another one, stones, things like that. Gastroparesis, in case you don't know, is a thing where the stomach essentially is held in spasm, or essentially the nervous system is paralyzed, and so you're not getting any movement of food through the digestive tract. Obviously, hypoglycemia, that's part of what it's doing. It's raising insulin levels, and acute kidney injuries can also happen with this medication, which is why hydration becomes very, very important with these medications as well. And again, keep in mind that many, many doctors are not going to have these conversations with their clients. This is where obviously the experts in nutrition come in. We have to be the ones that essentially have these conversations with people, because we can decrease the chances of them having an emergency room visit by simply saying, do not go out and eat a bunch of French fries and alcohol and give yourself pancreatitis or an acute kidney injury because you were so dehydrated. You need to drink more water on these medications. You need to have smaller meals. You need to decrease your alcohol, which can trigger pancreatitis on its own. You need to decrease your fat intake. Otherwise, these issues can come up. There can be some eye issues. There can be some intestinal issues. And this is the big one probably most of you have heard about. The truth is, as much as this has been getting lots and lots of publicity, the research isn't really clear on this. It certainly has been shown in animals. It's unclear whether or not these medications are going to be increasing risk for certain cancers, especially thyroid cancer. But it's there, and you actually will see this now, I believe, as a black box warning on many of these medications, even though the risk is not completely worked out in the research. Now, the other thing is does the weight loss last? So a lot of people would say, well, why are we even using these drugs, Jade? Like, obviously, we got a diabetes epidemic, we've got an obesity pandemic, right? But do these things really work? Well, first of all, 4 to 8% of people can't actually finish them. The side effects are bad enough where they just stop on these medications. 66% have rebound weight gain after stopping. By that, I mean they gain all of the weight back and then perhaps then some. Of course, some people gain most all the people gain some of the weight back once they stop. But the reason we're having this talk together is there is a way that you can begin to reduce the risk of this, and that is with lifestyle effects. So lifestyle still matters. Now, one of the things that can happen with these medications, they can increase bone loss, they can increase muscle loss. This is why we definitely want our clients and patients walking. We definitely want them lifting weights. And we may want to be using other things that keep them on these medications. So here's a ginger root. The number one thing you can do for nausea for these clients, it also has some anti-inflammatory benefits, is to get them on ginger, which is easily accessible through the grocery stores. It definitely can help with nausea. Essentially, the best way to do this is peel it, cut it, chop it up, boil it, drink it as a tea. And also, you can get some of those, at Whole Foods and other natural health food stores. You can get real ginger candy. This can make a big difference for those who are having severe nausea on these medications. You also want to counsel your clients to have smaller meals, less fatty meals, to chew the food very well, to eat very slowly. This will decrease the risk of pancreatitis and other issues with food, and to make sure you drink plenty of water. It also makes sense to probably have a digestive enzyme that you tell your clients to take along with their meals, given that this can reduce digestive acid secretions and those kinds of things. So a digestive enzyme could make sense here as well. Now, a couple other things I want to cover here is this microdosing issue. Now, obviously, there are going to be two types of people you see who are taking these medications. Some are going to be severely overweight or diabetic. And these are the ones that you're going to see taking the standard doses of 0.25 to 2 milligrams of semaglutide. The doses are higher if they're on something like tirzepatide. With tirzepatide, you're actually starting at 2.5. So just make sure you get the nomenclature correct, because the starting dose for semaglutide is 0.25. The starting dose for something like tirzepatide is 2.5. But what you'll see is there are some people who do not look like they need to lose weight, who maybe have like 10 pounds to lose. They are also taking these medications, and they're taking doses that are below the starting dose. These are usually compounded medications, and many functional medicine doctors like myself will be prescribing at these much lower doses. Those will be doses at 0.1 to 0.25. What are we doing here? Essentially, we're taking away some of the food urges and things like that. Some people will still see some appetite suppressing happening with these lower doses and some anti-inflammatory effects. They just don't have the huge weight loss that other people have. Now, keep in mind that some people who are very overweight can start losing weight at these dosages, these lower dosages. That's why some people will start them fairly low. But again, most people are going to need to be up at least these doses to see weight loss. But I do want you to be aware there are people microdosing, and this is very different than what you're seeing with the injectable pen. Some injectable pens will give you the ability to give doses in different amounts, right? Will give you some doses in different amount. I don't know if you guys are getting feedback, but I'm starting to get feedback from somebody.
Ay, caramba. Y yo estoy bien lejos, yo estoy del otro lado.
You want to mute, Roxy? I don't know if you want to mute everybody just so we're not getting that. I don't know if you guys are getting that, but I am.
Ay, ay.
Jay, you are on mute.
Okay. Everybody got me now? Must have muted me when you muted everybody else. Okay.
Yeah, thank you.
Okay. All right, got me. All right, so the point I wanted to make here is that some of you will think you're microdosing simply because you get the pen, and the pen has different doses, a lower dose and a higher dose. That's typically not microdosing because those doses are typically in this range. A microdose is going to be below 0.25 and typically going to be a compounded medication. Does that make sense? The way to think about microdosing and these drugs that I like to think about these medications is to think about it like if you twisted your knee or got knee surgery, you're going to wear a knee brace for a little bit of time as your knee gets stronger, right? Well, think about Ozempic, semaglutide, and these different GLP-1 agonist drugs as giving you a metabolic brace, giving you the ability to control your food intake on a diet. It does take away many of these urges, which we'll talk about here in a minute. And so it can be beneficial for that reason. However, once you go off these medications, if you haven't strengthened the metabolism, then you're going to go right back to a weak metabolism in the same way as if you had a knee brace and you did nothing to strengthen the knee brace is just going to not help. It's going to continue to keep the knee weak. And so when I'm counseling my patients and clients on these medications, I tell them, look, just like a knee brace, we're going to give you a metabolic brace. But just like a knee brace, you have to work on strengthening the knee so that you don't need the brace anymore. Same thing with these medications. You have to work on the metabolism so you no longer need the medications. Otherwise, when you come off the medications, you're going to regain all the weight. Now, these do have a mental emotional effect. They can reset and suppress both physiological urges and psychological urges. Now, what do I mean by that? Well, here's the research on this. Basically, they are impacting the reward system, the dopamine centers in the brain, the habenula, which is actually the area of the brain that controls willpower, the amygdala, which is the part of the brain that is controlling fear. And many of us, when we get in sympathetic fight or flight mode, we will use different compounds to self-soothe, almost like a child sucking its thumb. Some people go for drugs, some people go for alcohol, some people go for sex, some people go for food, right? And so one of the things these medications are doing is they are helping the brain's reward system, motivation centers, and the way the brain registers fear and safety, and therefore some of the self-soothing mechanisms around alcohol, drugs, and food are reduced. And so they're looking at these medications for smoking, alcohol cessation, and other types of things. And I want you to be aware of that. It can reduce cravings. It can reduce wanting and desire. It can inhibit impulsivity. It can blunt some of the reward signals that you get when you eat chips or fatty foods. And so this is important to understand. And here's just a research study showing this in alcohol use, but we're seeing this across the board in addiction medicine. So I want you to understand that for many people, most of you, I'm speaking to the choir here, you understand that food is not simply a source of fuel for people. Food is a source of self-soothing and a source of stress reduction. And so you're not going to help somebody by telling them what to eat if they're using food to self-soothe and reduce stress, because it's not that they don't know what to do. It's that they don't do it because they're using food to self-soothe. And this is very much like an addiction. The GLP-1s can help with this. They definitely can help with this, but you're going to want to add something on if you know that someone is, quote, food addicted or dealing with this hedonic hijack. You're going to want to, when they're on these medications, make sure that you're doing something that helps them with that when they get off. And the major tool for that is going to be something like meditation and mindfulness. And so now when you're dealing with someone who's taking these medications, not only do you want them working out, getting their diet right, going for walks and getting their body moving to repair the metabolism that caused them to get on the medication in the first place, but you're also going to want to be doing something to help with mindfulness, things like yoga, things like meditation, things like breath work, those kinds of things. So now let's get into the lifestyle plan. So obviously now you should know everything there is to know about these medications. How do you counsel someone when they go on these to make sure they get the weight loss results? Many won't get the weight loss results they want because they're not doing the lifestyle stuff. This is going to amplify those results, and they're more likely to keep the results if they're doing all these things. So I want to make the diet piece very, very simple for you. So when I counsel people on diets, I don't tell them what not to eat. I focus on what they should eat. And what they should eat are what I call the 10 S's: soups, salads, scrambles, shakes, stir fries, skillet meals, smoothies, sours, spices, and just a small amount or a smidgen of their favorite foods. So I teach them this little alliteration: soups, salads, scrambles, shakes, stir fries, skillets, smoothies, sours, spices, small amount of their favorite food. And by the way, this is really, really easy, isn't it? Because they're all just versions of salads. A salad is a salad. A soup is a wet salad. A scramble is an egg salad. A stir fry and a skillet meal is a hot salad. A smoothie and a shake are basically blended fruit salads with some protein in them, right? And so essentially you're giving them the salad diet. In addition to that, you're helping them get vinegars and sours and yogurts and sauerkrauts and things like that, because those things release their own GLPs. And then spices do the same thing, especially more bitter spices and spicy spices. And of course, you want to teach them that they can have tiny amounts of their favorite stuff. You want to get them to be a taster of the sweeter, enjoyable stuff, not an eater of those things. So soup, salad, scramble, shakes, stir fries, smoothies, sour spices, skillets, and a small amount of their own. This is how to get them to eat better. I have done this for 35 years. I can tell you, telling them to stay away from French fries and don't eat that, or go on a keto diet, or any of that kind of stuff, telling them not to eat certain foods does not work as well as telling them what to eat. These are the things they should be eating. They also need to stay very well hydrated. Now, typically when we talk about hydration, we actually don't talk about food hydration, but some of the best hydration, especially for these types of people, are going to come from fruits and vegetables. And what we know, despite the amount of sugar that people think are in fruits, is that fruit with the fiber and water content and vegetables with the fiber and water content are one of the best things that you can do for these individuals. And so one of the things I like to do is get them, while they're on these GLPs, to get off the super sweet stuff and move them to fruit-based, water hydrating foods. This is why smoothies can be so powerful. They give you a little bit of a hit of sweet, but not so much as a dessert. Terms of supplements, just the basics: multivitamin, protein, fish oil seems to be most all these individuals need. And of course, you want them to be moving and sweating, primarily with resistance training if possible, because there are going to be some bone reduction and muscle reducing effects without this. And I'll give you a plan here in just a minute. And plenty of walking. Now, the research on walking shows that right around 7,000 to 10,000 steps per day is where you're going to start seeing weight loss effects if the diet is dialed in. There's no need for them to be doing, 20 and 30,000, steps. But the sweet spot does seem to be somewhere between 7,000 steps on the low end for weight loss and about 20,000 steps on the high end for weight loss. The bottom line, though, is they need to move their body. So again, think about this metabolic brace. Think about them going to come off these medications at some point. You want to get them acting, moving, behaving like fit individuals, getting to the gym 3 times per week, walking, hydrating, and eating appropriately. And of course, mindfulness and the kind of things that can be powerful there are going to be important. That's your lifestyle aspects and what you want to teach them. So what would this look like in practice? Well, first of all, they're going to be taking these medications 1 time per week, typically. So they take their dose, and then what we want them doing is getting in the gym for workouts 3 times per week, 1 to 3 times per week. They don't need to be doing it every day. I know some of us, like you and me, we love working out all the time. All they need to do is about 3 times per week of traditional weight training or something weight bearing. It can be classes, it can be just traditional stuff, it could be any of that stuff, but you want them doing weight bearing exercise 3 times per week. You then want them eating this diet: soup, salad, scrambles, shakes, stir fries, skillets, sour spices. You want them on this diet throughout. You want smaller meals, less carbohydrate and fat, staying away from fried stuff, chewing their food well, all that kind of stuff. And then you want walking 7,000 to 20,000 steps daily. This is the plan that you want to be thinking about with these medications. And so the final thing that you will talk about here before we end for questions is, how do I take a client or patient off? Well, we just covered some of that, but let's basically look at this really quickly. So first of all, one of the things you want to do as someone's beginning to come off these medications is you want to be looking at this. There is some people who will begin to wean them off and start dialing back on the amount. So maybe one thing you could talk to their physician about, or if you are the prescriber, you can essentially say, okay, I've got them on 2 milligrams of semaglutide, and I'm going to move them down to 0.25. And then I'm going to move them down to 0.5. Then I'm going to move them down to 0.1. And while I'm doing that, reducing the amount of GLP-1s that I'm giving them, what I'm going to do is start to increase the amount of GLP-1 they're making naturally. Now, I can do that through several things. I can do it through bitter tasting foods, cocoa powder. One of the reasons I really like cocoa powder for this is because cocoa powder, we're not talking about chocolate here. We're talking about cocoa powder that you'll bake cakes with or make desserts with. It has several different compounds in it that really help the brain. It's got preformed serotonin in it. It's got phenylethylamine in it. It's got anandamide in it. All of these things can be very good for cravings and focus and reduce the desire and want for food. It's also bitter. And so the bitterness also helps secrete GLP. So one of the things about cocoa powder, take a tablespoon, put it in water, stir it up, add some of your favorite, milk or almond milk or something like that. Can you add sweetener? Yes. Not too much, though, because you want the bitter compounds. Coffee works this way as well. So does hops and things like that. So if someone likes beer or something like that, some of those beers, as long as you're not over drinking, but some of those things can decrease appetite. Bitter compounds are something you want to get on board. The 2 easiest ones are coffee and cocoa. Have people put cocoa powder in their coffee, even better. The next thing you want to do is you want to teach them about sours. Their dressings on salads should be vinegar-based. Citrus in water, lemon water and things like that. Yogurts, sauerkrauts, these things can release GLP. You also want to make sure they're getting in plenty of protein. Higher protein suppresses appetite. And the GLP-1 effect of protein is pretty pronounced. Many of us know that when we amplify the protein intake in somebody And the fiber intake, part of the reason that that's having a beneficial effect in cutting appetite is because it's releasing natural GLP. So now all of these, the bitter compounds, you're releasing natural GLP. The sour compounds, you're releasing natural GLP. More protein in the diet, you're releasing natural GLP. You're also reducing the GLP-1 medications as you're doing this. So hopefully that's making sense. Then you get them doing some mindfulness and meditation so they can find a way to reduce stress without freebasing cookies and eating sweets all the time. You get them walking, another way to stress relief, and you get them weight training. And all of this ideally would be going on once they start the medication. So over the course of the year being on these medications, you've helped them lose 30, 60 pounds on the medications. But by the time the year is up, their knee, the metabolic brace, their metabolism is now strong, and they act and approach life as a fit, healthy person. So they're not one of the 66% or 80% or 90% who gain all of the weight back. And so that's how you basically manage these medications. And so what I will do now is I'll end here and see if anyone has any questions that they want to go through. And I don't know how you want to handle questions, Rox, if you just want people to jump in or how that works. It looks like we got some people raising their hands. So, Alonzo, do you want to, I guess you could just unmute and you can ask. So I see Alonzo with your hands up, and it looks like you're unmuted, Alonzo, but I can't hear you. If you wanted to ask a question. All right. I don't know. Can you all hear him? I can't hear. All right, Rosario, do you want to go?
I believe that's me, right?
Okay. Yep, that's
Okay.
you. How are you?
How are you? Thank you very much for the information. I know that all my colleagues are really interested in this team. I have two questions. The first one is like maintaining doses for a long time, or it's just like the decrease, the escalation, the doses for the patient.
Yeah, so typically what happens is the dose is increased to the dose where they start getting results, and then that dose is stayed on. They stay on that dose until the desired weight loss. So let's say I was treating you and you said, hey, Jade, I'm interested in taking this medication. I might start you at 0.25 semaglutide, and then we'd watch you and see. And let's say after 4 weeks you weren't losing any weight, I would probably bump you up to 1 milligram at that point in time. And let's say you're losing some weight, but we want it to go faster. Maybe I bump you up to 2 milligrams, and now you start really losing weight. And now I just leave you there. As long as your side effects are, you're not having a bunch of side effects, I leave you there. And let's say you'll stay there over the course of, let's say, 6, 7 months. And at 6, 7 months, you've lost, let's say, 30 pounds, and you're feeling and looking good. What I would do is I would begin to reduce that then. I would say, okay, let's move you to 1. Let's move you to 0.5. Let's move you to 0.25, and then we would discontinue. Now, every physician is going to do this differently, but that's how I would do it with you. Now, some physicians will start you right on 2 milligrams and then take you right off. I don't like to do that because what I have seen is that can cause more side effects on the front end and also a kind of whiplash effect of increased appetite on the other end. Some physicians, though, would tell you they don't see that. But I certainly have, and I want to try to reduce that as much as possible. So what I do is work your way up and then work you down. And during that, I'm counseling you on all the things we talked about. Does that make sense?
Yes. It's like there could be like they just use the medication like once a month, or something like that, or it's just to have to be like weekly to
Yeah, so
reduce
you're
the doses, the doses?
so good question. So the question, if I'm understanding correctly, is saying, could you, instead of doing it once per week, do it once per month? Well, because of the way the half-life works, typically it's once per week, because after about a week, the medication is getting out of your system, right? And so, typically we don't do it that way. Typically we do it weekly and just lower the dose. There may be some physicians who do it that way. I don't necessarily do it that way.
Thank you. And the last question is, the cancer is related to any types of the medication, the duals, the triple, semaglutide only, is the
Yeah,
GLP-1 only, is the
yeah,
relationship? Yeah.
yeah. Good question. So right now the link is with all GLP-1 agonists. We don't necessarily know from my reading of the research that the dual agonists are having any better or worse effects. But that research is on the GLP-1 agonists. So I don't believe they've looked at it separate to be like, is there more increased risk with the dual action versus the single action? I will say this though, we can speculate a little bit. The body is used to seeing GLP and GIP together, right? So you would think that that's a little bit more natural for the body versus a very high push with GLP-1 just alone. But we can't. But the research on that is not clear to me. Someone else may have some more research on it, but I don't think they've distinguished. And that research link is tenuous, just meaning that a lot of us are not necessarily convinced. We have to say something. They have put an FDA black box warning on it. But that link is not strongly established, from my perspective, from looking into research.
Thank you very much.
My pleasure. Anybody else? Is it Raquel or?
Yes, yes.
Hi.
Is hello.
Hi.
Is a thyroid condition contraindication for the use of the medications?
Yes. So some doctors are asking about that. It's like, do you have thyroid issues that run in the family, or thyroid cancer particularly? And right now, out of an abundance of caution, I probably would myself turn someone away from that. And here's how to think about this. It's just like with pregnancy, right? It's like we typically say, out of an abundance of caution, you probably should not take, this thing that we don't know anything about or enough about when you're pregnant. So that to me is kind of where we come down on this. Now, hypothyroid, many clients I have on GLPs that have hypothyroid, and you'll see those conditions sort of go hand in hand. So I would say the contraindication, and it's going to again be up to physicians, but I think most of us, given the idea of thyroid medullary cancer being a concern, simply out of an abundance of caution and to protect ourselves from malpractice, we would probably say, we're not going to give you this medication if you have a family history of that. Now, some doctors may, I wouldn't. But certainly hypothyroid is not a contraindication. And hyperthyroid, typically these people are very thin. You wouldn't be giving this medication anyway. Does that make sense?
Okay.
And I saw somebody asking for the link to the slides. So let me see if I can put that back in the chat for all of you.
Can you
See
hear
if you,
me?
Yep, I got you, Ross. Go ahead.
Okay, there's some questions on the chat. There's one from
Okay.
Maria Ocasio that says, if patient is diagnosed with metabolic syndrome with dyslipidemia, HBP, obesity, and insulin resistance, is it safe to use one of these medications? If yes, which one?
Absolutely. As a matter of fact, that particular client would be who these medications are designed for. And either ones, would be tirzepatide right now would probably be the one that I would choose. Now, again, this is going to be up to different docs, but tirzepatide or Mounjaro has the better results. You will see people's lipidemia clear up. Remember, it's metabolic syndrome, high blood pressure, dyslipidemia, high triglycerides. All of these things can be addressed by these medications. They also have some anti-inflammatory effects. So in fact, someone with diabetes or metabolic syndrome or prediabetes, this class of drugs, this class of medications is highly indicated here. So I don't want you to necessarily think these are just for weight loss. They certainly have more effects. You also will see, by the way, you will see people who have joint pains and other kind of inflammatory conditions feel much better on these medications. So they do have anti-inflammatory effects as well. So absolutely, that would be indicated for that particular patient.
Okay, there's also Carmen Nevares have a question.
Yes, hi, doctor. Thank you for your very good conference. So I'm going to take some advantage, and I have 3 questions. The first one is about, at least here in Puerto Rico, there are some people selling some kind of natural GLP supplement. I don't know if you have some information about that. Does they work as are they good standing option? Second, for the regular treatment, for how long you recommend that this medication should be taken? And about the regained weight, do you think that the regained weight after stopping using the medication should be more related to that the people doesn't change food habits, or is about some alteration about GIP or GLP-1 production?
Yeah, thank you for those questions. So the first answer is there are many things that naturally will release GLP. There are different probiotics that are being sold because they will help with GLP. The issue is, just like we talked about in the beginning, is that they can enhance your own natural GLP-1 production. Cocoa powder does this, protein does this, fiber does this, certain probiotics do this, sours do this, yogurts do this. The problem is our own GLP-1 has a very short half-life. So it's one of the reasons why we tell people have a higher protein diet. It can have an effect. It can have a satiety reducing effect. However, it's not going to be as powerful as these medications. That being said, are they having impact on your own GLP-1 production? Yes. Just so we're all clear, every single time you eat, depending on what you eat, you will release GIP and GLP. These are natural compounds being released from the system. These compounds are acting shortly in the body. They're not around for a long period of time. The medications last much longer. And the medications are not quite identical to our own. That's why they last much longer. So it's not exactly the same thing. Although some people might get good results from those products. But the best thing we can do as practitioners is increased protein. Now, your second question about how long do people stay on these medications, typically what we do is we say, okay, if they have metabolic syndrome or diabetes or weight loss, let's say you got someone who's 50 pounds overweight, what you're going to do is you're going to look and see if they're a good candidate for this, right? So you're like, okay, you got 50 pounds to lose. If you're doing your due diligence as a practitioner, you want to ask them, what have you tried? Right? If they've never tried, now, of course, most physicians probably aren't going to do this because we know we're going to get pushback. But if this person has never tried lifestyle at all and they want to jump right to these medications, I'm going to try to get them not to do that. I'm going to try to say, let's do lifestyle stuff first and see if we can get some results. Now, we all know that most people are going to want the medications and they're not going to do anything except with the medications. And if that's the case, I still will prescribe it because from my perspective, being obese and having metabolic syndrome is much higher risk than any of these medications. And these medications actually might be the thing that motivates the person to finally become a healthy, fit person. how long do you leave them on them? Once they've lost the amount of weight that they came in for, right? So they've lost 50 pounds, you start weaning them off. And so that's basically how long that you would want to do that. And I think your final question is, how long does it take? I forget what your final question was, but just in case, it takes, typically we have 6 months to a year on these products. But what was your final question?
Yes, my final question was about the regain weight process.
Okay.
Is because of maybe some alteration in the GIP and GLP-1, or
Yes.
is because of way of living and eating?
Yeah, it's going to be, I know we would all like to think it's just a way of eating, and they can maintain this, but like we talked about, these medications have an impact on the brain. They affect the habenula, they affect the amygdala, they affect dopamine signaling. So they're going to be far more likely to have the same cravings and the same food drives again. This is why meditation and walking and all these things become an issue. So not everybody is going to be able to stave off the weight gain through lifestyle effects. However, what I have seen is the people who make the lifestyle changes while they are on these medications do very well keeping the vast majority of the weight off.
Thank you very much.
My pleasure.
We have another question here from Carissa Fuller. Can you describe what an adequate exercise routine might look like for someone on these medications? I'm particularly interested in what would be an adequate strength training routine. For example, for someone who is unable to go to a gym or does not have access to weights for strength training.
Yeah. Well, first of all, the most important thing, walking above all else. Get them moving. So I would say get them being a mover rather than a sitter. So that comes first. But in terms of weight training, I could give you a very simple routine that they could do if they just had dumbbells at home. So for example, you would basically just give them a set of dumbbells, maybe 15 pounds. They do 12 squat and press, right? So they squat down, stand up, press the weight. They do 12 lunge and curl. They do 12 push-ups, and they do 12, let's say, sit-ups. And they just repeat that in a circuit. 12, 12, 12, and 12. And they do it for 20 minutes. And they push until they can't, and they rest until they can. So they just keep going. So let's say round one, they get 12 of the squat and press and 12 of the lunge and curl. And then they only get 5 of the push-ups. Then they just rest as long as they need to until they're ready to go again. And then they start right at 6 push-ups. And then they get 6, 7, 8, 9 push-ups. Then they rest again. Then they get 10, 11, 12 push-ups. And now they're on to the sit-ups. And they just repeat like that for a period of time, 20 minutes. So that would be a very easy circuit to do if someone had no access to a gym. If they did have access to a gym, typically what I would do is give them 4 exercises to do. 1 for lower body, 3 for upper body. So like a leg press, a push from the chest, a pull, and maybe a press with the shoulders. And they basically do 5 sets, 3 to 5 sets of 8 to 12 reps of each of those exercises. And they do that 3 times per week. That would be the simplest type of exercise they need. We do not need our clients to be fanatical about being in the gym. But if they get into the gym, and you can let them know, and this is typically what I do, is I typically say, look, you'll lose weight on these medications, but you don't want to be flabby. You don't want to lose muscle and fat. What you want to do is lose fat. So if we can increase your protein intake, increase your walking, and increase your resistance training while you're on these medications, you will lose mostly fat, and you can look more athletic as a result. And so what I do typically when I'm counseling clients is I use that idea of like, look, when most people think about losing weight, they don't think about losing, being a smaller pear shape or a smaller apple shape. And that's what will happen to you if you just lose the weight. What we want is to transform your body from a pear to an hourglass. or from an apple to a V shape. And people typically will respond to that. So what I say is if you want that V-shaped athletic look, if you're a guy, you need to do resistance training with these medications. If you want that hourglass shape as a woman, instead of becoming a smaller, more flabbier pear shape, then you're going to want to do resistance training. And so you just have to do some psychological counseling with some of these individuals, if that makes sense. I see another question here. How would you work with a patient who cannot walk due to a knee problem? So the idea when I'm dealing with people with these things is you can always move, right? So it's like, then you get on a stationary bike, right? Or you just do the resistance training and you don't do the walking. You get these people moving, right? Here's the thing, they have to move anyway. Right? It's like one of these things that people say, like, well, squats, what if squats bother my knees? I'm like, well, every time you sit down in a chair, you're squatting. Every time you go to the bathroom, you're squatting. So we need to get people moving. So the idea is that with knee problems and joint problems, you still have to get them to move. And a hint for that, for those of you who are not experts in exercise, is anytime you've got joint issues, elbow issues, knee issues, those kinds of things, resistance training is the thing to do, and you want to focus on the eccentric lowering portions of those movements. So for example, when you're doing a squat, if you've got knee issues, squats are wonderful for knees, but focus on slowing down on the lowering phase. If you're doing leg extensions, slow down on the lowering phase. Eccentric focused repetitions will help the knees. Also, these medications oftentimes will take that pain away. Now, what you don't want to do with someone who has knee pain, who starts to see the knee pain decreasing on these medications, is have them just go out and walk a ton, because then they'll injure their knee. Their knees are not strong enough to do that. It's better to start the walking slowly. So what I typically do is I go, look, if you're not walking at all, if you're less than 3,000 steps per day, let's get you doing at least 3,000 steps per day. Once you've gotten that done, let's make sure we take you up to 5,000. Some of the big issues are going to happen when you go, hey, I want you to go from doing nothing to now all of a sudden you're a CrossFitting paleo person, right? You got these people walking like crazy. You want to ramp people up slowly. I've even had people in my practice where I will literally have them sit on their back, lie down on their back, and move their legs in the air as they're pressing their arms. And I do that in intervals. I'll have them do 1 minute on, 1 minute off. And I've seen people get better and better, right? So you just start wherever they can. I see another thing here, coconut powder or coconut oil, which is better for metabolism. Well, okay, so coconut in general has lots of short chain and medium chain fatty acids. So many people have heard that taking short chain fatty acids and medium chain fatty acids will, quote, stimulate metabolism. And it does a little bit. As a matter of fact, if you wake up in the morning, you have a spoonful of butter or a spoonful of cream or a spoonful of coconut oil and nothing else, your body can produce some more ketones and things like that. The problem is these things come along with calories as well. And the amount of calories you consume typically outweighs any sort of boost that you get in metabolic rate. What we probably want to be teaching our clients is that they don't want a fast metabolism. They want a flexible metabolism. And so these sort of foods where we're focusing on, oh, eat some coconut powder or eat this, it boosts your metabolism. It's probably a misnomer. But to answer your question in particular, coconut powder or coconut chips or plain coconut flakes, these come with fiber and some fat and are going to probably be the better thing to have if you're going to be consuming coconut. One of the things that I will tell you, especially as it pertains to GLP and GIP in the gut, if you want more GLP, you want to try to remove the fat sugar combination or the fat starch combination. So potatoes and butter, rice and oil, French fries, fried chips. These are the things that are going to be the biggest issue. They're going to get much more GIP in there. So if you're going to be eating foods and you want to help people do better while they're on GLPs and GIPs, you probably want to focus on getting them to eat protein and fiber first. Soup, salad, scrambled shakes, stir fries, skillet meals, just like we talked about. Then fat and fiber. Last, fat and carbohydrate. What I typically tell my clients to do is typically if you want more GLP, you want to learn to eat your protein. And there's research showing that if you have a plate and you've got chicken on your plate, broccoli on your plate, and rice on your plate, if you eat the chicken and the broccoli first, you'll get more satiation, you'll eat less of the rice. And so what I typically try to teach my clients that are trying to lose weight and amplify the GLP effects of these medications is to eat their protein and fiber sources first, to then eat the carbohydrates a little bit more sparingly. And not because there's anything wrong with carbohydrates per se, it's just that those are the things that people will tend to overeat the most. They're not as satiating. We all know what it's like if someone gives you a potato chip or a cookie. Because of that fat, sugar, salt combination, you can't just have one. They even market it that way. But how many people do you know? Like, I know a lot of people who can overeat a donut. And think about it, a donut and a chicken breast have the same amount of calories, 250 calories. 300 calories for a donut and a chicken breast. Now, I can eat 5, 6 donuts. I don't know about you. Why can I eat 5 or 6 donuts? Because that fat, sugar, starch, salt combination triggers my hedonic response. I'm not going to sit around and eat 5 or 6 chicken breasts. This is what you want to be thinking about, right? No one's going to sit around and eat 5 or 6 chicken breasts. They're not going to be able to eat that much. This is part of what we want to understand. It's not the calories. It's the communication that the food is sending. Broccoli, fiber, and protein in that chicken breast without a lot of fat and starch send a hunger-suppressing signal to the metabolism. Versus a donut with a lot of fat and starch and sugar sends a eat more signal to the metabolism. It's a good way to think about these medications too, because these medications are essentially having a chicken breast broccoli signal being sent into the body. Does that make sense? So I wouldn't get too caught up in these ideas of should I eat this stuff or that stuff. What I would do is just stick to the basics here. So hopefully that helps. And then I see another one here. If the person used the medication after quitting gain weight, can they start using it again? A person that already has a bariatric surgery and then gains weight, could they use this medication? Yes, they absolutely could use this medication. So I think what you're asking is, let's say someone's already been through a bariatric surgery or they've even used these medications before and then they've regained the weight. Can they use them again? Yes, absolutely they can. Any other questions? And yes, you all can, I saw that some people asking, you can follow me on Instagram at Jade Teta. You can follow me on Substack as well. I don't spend a whole lot of time on Facebook, but. Any other questions? Okay. Roxy, you have anything else?
Hi, doctor.
Hi, go ahead.
I have a question. If I have a
Sure.
client or patient that is having GI disturbances like nausea or vomiting despite recommendations of a low-fat diet or maybe using ginger, do you have any other dietary recommendation or do you recommend to decrease the dose or maybe discontinue the dose of the medication in order to assist the patient with that?
Yeah, great question. So first thing I would do, if they're already at the dose and they're already losing weight, I would basically use ginger and get them on ginger, either decocting ginger, which basically means boiling it and making it a tea. They should consume that prior to eating. And also when they're when they're on an empty stomach. So just use it as a beverage. You can make a lot of this. You can make a ginger lemon sort of mixture. That's the first thing I would do. Try that first. Smaller meals. Try that. Also, just so you know, and this is actually documented in the research, there's a spot right here. I don't know if you guys can see me, but this spot right here between the thumb and the forefinger, that is a spot that you can press and massage that actually has been shown to reduce nausea in some people. So you can teach them that acupuncture or acupressure point to use as well. And if that stuff doesn't work, then yes, you're going to want to decrease the dose, dial it back to where the nausea is not there. Now, typically, you can avoid that nausea, that severe nausea, by starting slowly. So I'm sorry that your client is experiencing that, but that's what I would do. Let's see. So I see Carissa says, would you recommend postponing or reducing doses of these medications for individuals who have a poor appetite and are already consuming a very low calorie diet? Actually, I'm glad you covered this one, Carissa. Thank you. Here's the thing. You will start seeing some people using this, and some doctors who they're relatively thin, they're using it, and it's bordering on, some of these things that we all know, that people just want to look better, look good, and they're drastically decreasing their calories to do that. That is not the indication for these medications. Let's just be clear, and you have to be careful. So there are some people out there doing that. Typically, though, what you want to do is some people will have some of these drastically suppressed appetites, and they're actually losing weight. And by the way, there's nothing wrong with that per se, because where are they getting the energy to support their life? They're getting it from the fat they're burning. However, you do want to make sure that they have adequate nutrition. So this is where dietary supplements come in. What I like to do is a good quality fish oil and a multivitamin, multimineral, and a good quality protein shake, right? So those are the things that you get on board. That way they're not, because what are the big things we're going to be worried about? We're going to be worried about stripping off muscle off the body. We're going to be worried about creating nutrient deficiencies. You don't want that. So across the board, what I want is fish oil. I want a protein supplement, and I want a good quality multivitamin. And at that point, so long as they're getting their nutrition in, they still have weight to lose, and they're feeling good, then I'm not upset about the weight loss. They should not be staying on this past adequate weight loss, though. So I would be pulling them off of that after that point in time, right? Next question. How much weight is healthy to lose in a given period of time while using these medications? Well, let's look at this. This is a really good question, but let's look at it this way. Like, let's say you and me, we were overweight and we wanted to go on, let's just look at it this way. Let's just say for some reason we were on a fishing trip and our yacht broke down and we got stranded on an island and we couldn't eat much and we were forced into a very low calorie diet, right? How much weight would we lose? Well, you could lose, 20 to 30 pounds in a month, depending on how severe that was, right? But in general, you want to think about that amount of weight being lost over about 6 months, right? So if you're kind of like, well, how much weight should they be losing? The general rule of about a pound or 2 a week at most, 2 pounds a week at most, right, would be kind of where, that would be on the faster end of things, for most people without these medications. Now, when you're on these medications, you could probably double that, right? So you could probably say people are going to be losing, they can lose faster than that, maybe, 5 pounds a week. But typically it's going to be with these medications somewhere, once you get the dose right, they're going to typically be dropping about 2 to 5 pounds per week. Keep in mind, some of that is water weight and that kind of stuff. And then that's going to get you to about, upwards of 10 to 20 pounds per month on the high end of things. And after about 6 months, you can see people up around, 30 to 60 pounds, depending on how much weight they've lost. Most of the time, though, you want to think about that over the course of a year, right? Where it's like, if someone has 100 pounds to lose, you want to be thinking about them achieving that over the course of about a year, right? So hopefully that makes sense. Will some people lose faster? Certainly, yes. Okay, any other questions? We all good? All right.
¿Alguna otra pregunta? Is there any other question? Can we, okay, have a copy of the PowerPoint. Sí, Carmen, aquí en el chat está el link para el PowerPoint. Lo voy a poner ya mismo otra vez. ¿Alguna otra pregunta para Dr. Jade? Sé que dice Annelise, pero es Roxana la que está hablando. Estoy usando la cuenta de Annelise, por si acaso. Es Roxana Tosca la que está hablando por aquí. ¿Alguna otra pregunta? Ok, pues muchas gracias a todos que se presentaron aquí en el día de hoy. Gracias a Dr. Jade. Thank you so much. Así que stay tuned because Jade is supposed to be here for August 2026, so you can meet him in person. Así que esperamos a Dr. Jade en el verano agosto 2026 para que lo puedan conocer en persona. Y pendientes que nuestra próxima actividad es el simposio, primer simposio de nutrición pediátrica y neurodiversidad, el 14 de noviembre en La Goya. Así que si no estás matriculado, ya sabes, dan una llamadita. Así que muchas gracias por su atención. Thank you so much, Jade. And see you soon.
Thank you.
Thank you. Thank you.
Wait.